Welcome, everyone, to Infertility 101. My name is Dr. Nathan Barhama. I'm a reproductive urologist focused on male infertility, and I'm really pleased to be able to share this discussion with my colleague, a reproductive endocrinologist, Dr. Rachel Gerber, who will introduce herself, and just really to highlight the importance that, looking at the male and the female together is important. To have a compassionate and couple-focused approach to the difficult issue of infertility.
Hi, I'm Dr. Rachel Gerber. I see patients in the Westchester office of RMA New York. And we also have branches in Long Island, Manhattan, and Westchester. And Dr. Barhama actually sees patients from all sites. So, it's very special that we have a male fertility specialist as part of our group. And he really serves the full gamut of our population. So I'm going to first go into what to expect at your first visit with a reproductive endocrinologist, an infertility doctor. The first thing we do is really discuss your history, get an understanding of what your menstrual cycle's like, which is a huge piece of the puzzle right off the bat. Specifically if there's any menstrual irregularities, then that may be right there a contributing factor to infertility and would lead us towards a workup for things like PCOS or other such things. And so that really is a primary initial piece of information that you need when discussing an infertility workup. Additionally, we also want to know if you've ever been pregnant before, ever had pregnancy losses, because we also manage pregnancy losses, recurrent pregnancy losses, and there's a workup for that we definitely do if that applies. Once we get your history in terms of your menstrual history, your past pregnancy history, we then would go into your GYN history. Have you had any pelvic infections, any pelvic pain with periods that may indicate something like endometriosis, which is a condition that can cause inflammation and scarring in the pelvis and lead to infertility in various different ways. And so that's part of the history. Do you have fibroids? Do you have any history of ovarian cysts? All of those things are important in understanding what might be underlying the cause of infertility. Again, the assessing for ovulation is really fairly, if you have regular periods, you're 99% ovulating. But sometimes we have discussion of, are you tracking ovulation? How are you timing intercourse? And make sure that that's all optimized. Something that I do find fairly often actually is that when I start digging into sexual function, I frequently find that there is something to be said for either pain with intercourse that may lead to infrequent or difficulty with intercourse, or issues with erectile dysfunction or ejaculatory dysfunction. And I've heard a lot, a reasonable amount of time that sometimes males, they have what I say, it's almost like anxiety around having to do it at a certain time, and it's all riding on this one day, and all of a sudden the anxiety and the stress of needing to perform can really get into the head of some men. So that is something that I've heard over and over, and a lot of times people are shocked that I say, oh, I hear this all the time. They think they're the only person who has this issue. It's one of those issues that's difficult to talk about. And honestly, I almost have to ask explicitly for the information, or it won't be told because there's so much stigma around it.
And Rachel, I think I would reinforce that by identifying it as a common issue is critical, but also important. It's easily fixable. It's, anxiety and having, being stressed is something that's expected, and it will impact one's erectile function. But Viagra and all these agents are safe. They're used by millions of men, and there's no reason to suffer with this, issue. It is really often easily treated.
Yes. And one thing I often will say is sometimes it ends up being a cycle in the relationship where the female partner will start getting frustrated, and then that worsens the situation, so it's almost like this perpetuating cycle where you really need the couple to be a team and understand that no one is meaning to cause this, and kind of take the stress off of placing blame, which can be something that unfortunately happens when there's, so much riding on, every month. But that is a really important part of my history, is taking a very explicit sexual history, in terms of, is your partner able to ejaculate in your vagina? I say things like that straightforward, because or else they just will leave information out if you don't get that
I
detail.
think what you also highlighted is the concept of everything is riding on that month. And I think that
Mhm.
part of what we try to do at RMA is to look at the male, look at the female, get data, understand what's causing the possible fertility challenges. And I often try to say, let's shift to a 6-month plan. Okay, what is the
Mhm.
strategy here based on the data and the workup? And very often that does tend to relieve some of the anxiety and stress, because it's not each month that is its own event, but rather we have a coordinated 6-month strategy. And very often that helps reduce the stress as well.
Mhm. So, once we have a history right there, we frequently may have some areas to address in terms of ovulation. Is there any risk factors for fallopian tube disease, like pelvic scarring, history of infection? And from there, we really go on to our version of a physical exam, which is essentially a transvaginal pelvic ultrasound. So the pelvic ultrasound is critical, and what we do is we look at the uterus. We assess for anything that could be affecting implantation on the inside of the uterus, whether it be a fibroid, a polyp, which is a non-cancerous growth inside the uterus that could be taking up real estate that an embryo may be trying to implant on. And I also usually do something called a 3D ultrasound, which gives you the shape of the entire outline of the uterus to see if there's any what we call uterine malformations, which means that the uterus, when it developed, in as a fetus, was there any issue with the development of the uterus? And then we go on to the ovaries. We're looking for things like cysts, and sometimes we can see cysts that look consistent with an endometriosis cyst, which will give us information about that particular diagnosis, which can lead to infertility in various ways. And we also get something called an antral follicle count, which is where we see how many follicles, each of which contain an egg. So we see how many eggs there are present in the current ovulatory cycle that you are in, from which you are choosing your follicle for ovulation. So each month there's a new batch available, and ultimately only one egg ovulates a month, because we, humans are meant to have one baby at a time, although sometimes it goes a little faulty. The we are set up for one baby at a time. And so there'll be a pool of eggs available at the beginning of each month, but ultimately only one ovulates. That pool of eggs, though, has some importance, because that's what is available if you ended up needing fertility treatments with IVF. And so ultimately, it gives us an idea of what your reproductive lifespan is in terms of how many eggs you have compared to your peers or age-matched peers. And then also how you would do if you were to need IVF or egg freezing or embryo freezing, because ultimately that's the pool that we have to stimulate in an IVF cycle. So from our standpoint, that's really the basic 101 of what we're doing at our initial visit. And I'm always very proactive about getting the male partner scheduled for a semen analysis. I don't let them leave the office without scheduling it. I almost borderline harass them to schedule it, because the second they walk out the door, I feel like it's a missed opportunity. And I even will have the women, some when it's the men aren't there, I'll be like, oh, why don't you call them? Go to the front desk, call your partner, see if he picks up and get it scheduled. So I am very, I like that, to get as much done and as much scheduled in that first visit, because ultimately once somebody leaves and then they have to reach back out to us and go through a call center and then get connected with the front desk, that's that's another barrier. Is So to me, we must set it up, um at whatever moment we can. I'm going to take that to make sure that we're scheduling that semen analysis, because men contribute to infertility, you know, very frequently. There's studies say, even could be about, we say, a third is female infertility alone, a third male fertility, and then a third of combined. So if I have a patient that has anovulation and we know that the reason they're not getting pregnant is because they're not ovulating, I still recommend to get a semen analysis off the bat, because if we're going to work so hard to get you to ovulate, with Clomid and letrozole and ultrasounds and blood work, I think we should make sure that it's not all for nothing, and that our sperm is adequate for intercourse or for IUI before we have you going through, ultrasounds and waking up early in the morning and taking these medications. So I would say, just because there's one thing doesn't mean there's not another. And so, because the semen analysis is a fairly simple, not painful test, I stress to get it up front, even if we know that there's an issue on the female side up front.
And I think that those are the current guidelines. The current guidelines really highlight the fact that, as you said, right up front, we want to have the data on both the male and the female, so that we can really start understanding where the etiology is and what are the factors at play, as well as realizing that in about 30% of the time, there's a combination of factors. And getting back to that semen analysis, I think that it's important to highlight that we've kind of post-COVID really realized that we can do better. We can really bring care to the patient. Having a Zoom telehealth encounter with the male and at his work, or at home, without having to come in, to highlight and understand risk factors, medical comorbidities, as well as scheduling a semen analysis, really makes the process much smoother. I think that it's also important to realize that we have some new technologies. We just published a paper on the largest series to date of home testing. It doesn't give us all the information, but one of the most difficult experiences as a clinician dealing with couples is a woman or a couple that have been trying for a year, and the individual did not have any sperm at all. Right from the onset, we should have known that. We could have known that. So I encourage home testing, home collection. We have technologies where you can collect at home and ship it to a facility, or, as Rachel said, if you're coming in, to schedule it in our labs. But getting an analysis, getting engaged, understanding your risk factors has really evolved to make it much more comfortable and accessible to the male.
Yes. And another thing that I think is nice is we do allow for home collection, so that, they can bring a cup home, collect the specimen at home, and as long as they can get it to us within an hour of collection, that they can, a male can produce at home if they're more comfortable. Some
And
men,
I would
some,
just add to that,
yeah,
there are new designs. Just think of it. If you're getting a hot cup of coffee in the morning and you put it into a regular cup, it's going to get cold fairly quickly. But if you put it into one of these more advanced, I'm not, pop culture cups that really preserve the temperature and preserve, it for an extended period of time, we have those type of collection containers for sperm. And so therefore you can go ahead and collect at home and expand that 1 hour window to several hours and feel that the sample is adequate.
Yeah. So from my perspective, I'm gonna turn it over to Dr. Barhama to talk about, the male workup and what goes into that. Oh, actually, I want to bring up one other thing. I personally have been seeing a lot of men on testosterone. I feel like this is something maybe every other week I'm encountering. And unfortunately, sometimes they even ask, is this going to affect my sperm? And primary care doctors said no. So this is something that I like to ask up front because it helps understand why sometimes we get really, poor semen analysis. And I think it's unfortunate the misinformation out there about that.
Right. I mean, I think that very often some of these clinics or the rejuvenation, centers focus on testosterone without fully explaining the risk of becoming sterile. It's not just the count is going to be low. Normal testosterone supplementation in over 90% of men will cause sterility. And so it's important to understand if that's going on. There are things that we can do to kind of counteract that. One of the things that I find challenging is men on testosterone really are fearful of just stopping it because they do feel better. They do feel that there was a need for it and there's a benefit. But we can titrate. We can, transition them to other medications that really don't diminish the testosterone level and really prevent the side effects. So it's important for men to appreciate that opportunity and option exists. The other thing that I would say is, testosterone deficiency is common in men with infertility. 20% of men with infertility have low testosterone. And it's picked up or diagnosed with with our initial evaluation. Now that has implications beyond fertility. You need good testosterone levels to optimize your sperm production, but you need normal testosterone levels for muscle mass, for bone health, for to counter obesity. It's important for sexual function. So having a low testosterone is an important diagnosis to make as part of the fertility evaluation and is part of that 101 evaluation. The initial evaluation of the male is both a history, an understanding of risk factors, that semen analysis, as well as testosterone levels. The other thing I would just want to ask, Rachel, maybe you can just expand. One of the things that I really try to highlight in the initial evaluation is that things can be done in parallel. Right? We don't have to be sequential. We want to find out what's going on the male, what's going on the female. And I think that the initial period of this, understanding the landscape is critical, but it's also an opportunity to understand the pluses and minuses of things that we can offer as a fertility center to increase your chances of getting pregnant. And each of these options I think is important to just start discussing even right from the beginning. What is it? What's involved with trying to conceive naturally? Triggering ovulation, proceeding with intrauterine inseminations. What is that added success rate for IUIs? And what we're seeing a lot, I think, is an evolution and a different perspective on some of these more advanced options like IVF. right?
Mhm.
Because IVF, in my mind, as part of the initial encounter, is often perceived as an option of last resort, right? But we're
Mhm.
seeing many couples who come in their early 30s during that initial encounter. And I think it's important to start exposing them to the concept that, well, yes, it is more involved, but if you want to have 3 kids and you're already 35, okay, just like you would be interested in freezing your eggs to optimize and preserve your fertility, some couples say, well, you know what? I can do IVF. I can create embryos. I can make sure that those embryos are healthy. I can do PGT testing and all of a sudden put 6 embryos in the bank. And then all of a sudden you find yourself, having upfront created the family you wanted with a lot less anxiety or stress and a higher success rate. Maybe you can talk a little about, how you
Mhm.
engage and expose the couple right from the beginning about the
Definitely.
technologies and services that we offer.
So yes, at the initial appointment, when we talk about the infertility diagnosis, we address the kind of the basics of what we have to offer, which is if you are not ovulating regularly, then we can do as little as get you to ovulate regularly with an oral medication and help you time intercourse efficiently. Um, if you are ovulating, then you need a little something else besides just an oral medication. You need to at least combine the taking an oral medication like Clomid, which boosts your ovulation, maybe makes you ovulate 2 or 3 eggs instead of one. You have to actually combine that with an IUI if you are ovulating on your own, and that is not the sole issue. Um, in that case, you need really still a good number of sperm to even be in the range where IUI is helpful. So, what I say is ideally you have 10 million or more moving sperm in order for IUI to be an option. And if there is less than that, then it is reasonable to consider IVF right off the bat, just based on the semen analysis. But so IUI, the thing that's frustrating about it is that even in the best case scenario, it really only increases your chances a couple percent, a few percentage. So in a couple with unexplained infertility, which means like the tubes are open, there's adequate sperm, you are ovulating, you doing this combination of Clomid IUI gives you at most a 10% chance per month. And that's for a couple who already has been trying for 6 months to a year without success. So that couple, the chances that you get pregnant once you've already had 6 to 12 months of infertility go down to 5% or less. So, we are improving, but not by leaps and bounds.
But
And
let's just flip that discussion, to the next level, right? So I think it's very important to present what are you, based on the workup that we're doing, what are the success rates per month naturally? What are the success rates per month with IUIs, assuming that you have that threshold of 10
Mhm.
million moving sperm. But then I think that it's important to also describe the
Yes,
success rates that we have. And again, it's dependent on female age, but those success
mm,
rates have, astonishingly increased over the last decade.
definitely.
And I think that's also important to
Yes, and
describe.
a big part of our conversation from the first appointment is what is the ideal family size. So there's two ways of looking at infertility. It's, well, let's deal with having one baby, and then once we get that under our belt, then we'll deal with having the second baby. But I have a lot of patients, particularly if you want more than two, or if you're over 35 and want more than one, who we say, okay, so why don't we plan for your whole family, to complete your family, and deal with that now with IVF, because IVF can be a form of treating infertility and preserving your fertility at the same time. So you have that added benefit. So I have a lot of couples who say, you know what, I want to give myself an insurance policy or increase the chances that I will be able to have the family size that I want. And so IVF becomes the best option up front, even if they were a reasonable candidate for IUI. And I have couples that pursue that all the time.
I'm seeing a lot more of that, and I think that
Mhm.
it's really important, you know, not to push off these discussions
Mhm.
to several months of trying, but rather upfront, get the data, get the information, personalize it, understand what's going on in your specific situation based on the tests that we do, and then really, I mean, let's just describe the success rates for a 33-year-old female who has, the partner has male factor and the sperm is concentration is low, but they're candidates for IVF ICSI. What is her success rate?
So yeah, so it can
In
be
that
dependent
situation.
on egg counts, but if
Yep.
let's say it's isolated to male factor and that otherwise, you know, the egg counts are okay, what I say is that, the chance of pregnancy per transfer, per embryo, and you may actually be able to get multiple embryos in a single egg retrieval, but the per embryo transfer pregnancy rate is 60 to 70%.
Yeah, that's astonishing. Okay,
It
so I think
is.
that it's important to really highlight that, yes, less invasive options, or you may be more comfortable with.
Mhm.
But just, that's why I always focus on a 6-month strategy.
Mhm.
If you're choosing to go incrementally, and you want to try naturally, and we made sure that from a health perspective, everything is fine, which we'll get into that in a second. Just realize what your chances are, and feel that, certainly on the male factor component, your chances with a partner who has good fertility is extraordinarily high, using the technology of IVF with injection of the sperm into the eggs.
Mhm. Yeah.
And again, I think that what we're trying to highlight is these discussions don't have to wait. We can
Mhm.
have these discussions right up front, and we can, I say this so many times, we can walk and chew gum at the same time. We
Yes.
can work up the male, we can work up the female, we can discuss options. We don't need you to make decisions about how you want to move forward, at the initial encounter. But I think it's important after several encounters to understand what your options are. And most importantly is be flexible. One of the things that I always tell couples is, you may decide that you want to do an IUI 3 times, and then after the second IUI, you're really frustrated and you're ready to move on. That's fine. Be flexible. Give yourself the option of moving in either direction. But I think our priority and goal is to let you know what your options are, and the success rates associated with it. And that's also why it's important to have a reproductive urologist working closely with a reproductive endocrinologist, because
Mhm.
we can only give you good choices if we know what's going on both sides.
Exactly.
So I'm going to just, I'm looking at the time. We really do want to give the participants opportunities to ask questions. Um, so I'm going to try briefly to go through some slides. Some of them I'll go through quickly because we've touched upon it. Let me see how I can do that. So this is the real question, right? You're thinking about having a baby, and everyone is focused on the female. And the question that I want you guys and couples to explore is, could he be infertile? Could he be a component or a contributor and not know it? Well, we really need to appreciate the fact that in about 30 to 40% of couples with infertility, the male is a contributing factor. Okay, it's not an isolated issue, it's a very common issue. And as Rachel mentioned, and I'm comfortable repeating this as many times as we need to, is that the current medical guidelines are very clear. The male and the female should be undergoing an evaluation in a simultaneous parallel fashion. The days of having the women go through a hysterosalpingogram and do, undergo Clomid for 6 months and then see what happens is not the optimal way to manage a couple. And the evaluation of the male is not complicated. It's not intrusive. It's not painful. It's a discussion. It's understanding your risk factors. And as I mentioned earlier, it's sometimes, and it's very easy to do as a telehealth encounter. And then getting a semen analysis, which, as I mentioned, can be done through home testing, through home collection, through collection at home and bringing it into the facility. This notion of coming into an isolated lab and providing a sample in that uncomfortable environment is part of yesterday's medicine. Risk factors, right? Do you have any sexually transmitted diseases? Are you a male who's over the age of 45? That can have an effect. Lifestyles, prescription drugs, surgery to the testicles. Did you have undescended testes? Do you have dilated veins like varicoceles? These are all things that we can explore in our initial discussion. Let's talk a little about common sense, some of the things we talk about during the initial evaluation. Being overweight reduces your fertility. Okay, it's not good for the female fertility status or the male. And the good news is, if you lose weight, your sperm count goes up. The data is quite clear about that. Very often on the initial evaluation, we start having a discussion about risk factors such as smoking, alcohol, and marijuana. So what I would say is the following, and I often use this example. If you're baking a loaf of bread, right? And you want to optimize the quality. Everything matters. The yeast, the oven, the dough, everything is really instrumental and contributes to the quality of the overall product. And that's the difference between a great, loaf of Italian bread versus something that you get at ShopRite that is, has a shelf life of 6 months. Okay. And so this is how you, as men, should really appreciate, your sperm contributes to the quality of the embryo. We have very clear data about that. And this is an embryo and a child that you're going to have for the rest of your life. So it's really up to you to expedite the pregnancy and to optimize the quality of your offspring. The other thing that's really important is to appreciate that men with fertility have a higher risk of testicular cancer. So really, if we evaluate you and we do an ultrasound and the testes are fine, that's great. That's an important piece of data. It is not uncommon for me to pick up testicular cancer in the men who come in for an evaluation of their fertility. Cancer of the testes is common. It's treatable if it's isolated and small. So it's very important to identify it. So we do an exam. The reason the testes are outside the body is because they need to be about 1 to 2 degrees below body temperature. And the other thing is testicular size really is important. Testicular size, 90% of the testes contribute to sperm production. So testicular size does relate often to sperm concentration. We do blood tests. We talked about testosterone. We do other tests such as FSH and LH. And FSH is an important hormone for men, just like it is in women. It's a message from the brain to the testicle, make sperm. And if the body has an internal thermostat, a negative feedback system, so that if sperm production is diminished, the body responds to that and increases the FSH. It's like a gas pedal in a car. If the car is new and in its top line, you just have to touch the gas pedal, very low FSH, you get good production. If it's an old engine, it's stuttering, it's not producing a good output. You have to push down on that gas pedal, and that correlates to the FSH being elevated. So as we talked about, testosterone is a component of infertility. It's present in about 20% of men with infertility. And it's very important, as I said, it's important for brain cognitive function, for muscles, for your voice, for your bone density. Bone density is critical. As you get older, men can develop osteoporosis and have hip fractures. So identifying a testosterone deficiency early on is important. And as Rachel mentioned, a lot of these men are given testosterone without clearly appreciating the risk to their fertility. But we have ways of treating men who want to optimize their fertility with HCG. We have clomiphene, we have aromatase inhibitors. We have a lot of treatments available to overcome hypogonadism in men of reproductive age. Let's talk about the semen analysis briefly. It's a complex test, simple to do, but a lot of variables. Not every variable has the same predictive value. Okay, it's important to realize that some are more important than others. The sperm concentration, of which we want it to be above 40 million, is important, as well as the motility. Less important variables are morphology, which has a very low cutoff of 4%. If it's lower than that, you have to put it into the context of the concentration, right? So very often people come in, oh my God, I have my only 2% normal sperm shape, when their count is 150 million. So it's important to realize that normal is 4% of 40 million, while they had 2% of 150 million. So if you calculate it out, even though it's only 2% normally shaped sperm, as an absolute number, they have a normal number of normally shaped sperm. So I think what we want to highlight in this picture here is one of the most remarkable medical achievements in my lifetime. Okay, I'm a little older than Rachel, so I think Rachel, ICSI was around when you started. When I started,
Yes,
this was really just
definitely.
being developed. So what is ICSI? It's basically the capability in the lab under the microscope to take one sperm and inject it into the egg. So you need one motile sperm. The reason we need a motile sperm is because that's the way we know it's alive. But if someone has 10 eggs, we need 10 sperm. 40 million, 60 million is an irrelevant variable. And the sperm can be obtained from the ejaculate, but we can also use testicular sperm that's twitching. So this has really revolutionized our ability to offer good options for couples with male infertility. The only thing we can't really treat is if there is no sperm at all. If there's motile sperm, we typically have good options to move forward. One of the things I just want to conclude with is the most difficult situation is when people have what's called azoospermia, or no sperm at all. Very frightening, a challenging scenario, but I want to just split that up into 3 different potential options. Option number 1 is that there's no sperm in the ejaculate, but normal sperm is being produced in the testes and it's obstructed. There's a blockage. Okay, that's option number 1. And then there's the 2 other options is where we have some sperm production, but there's no blockage. It's a non-obstructive situation, but there's not enough sperm coming out. So it's like a teacup that has to overflow for us to see something in the saucer. But if the cup is only half full, right, we're going to not see anything in the ejaculate. But if we go into the testicle and search, we will find sperm. So that's scenario number 2, and that's a non-obstructive azoospermic scenario, but we tend often to see a higher FSH and the testes are smaller. And the 3rd scenario is when there's the germ cells or the cells that are responsible for making sperm are absent. We further evaluate those scenarios with genetic testing. We look at chromosome number. If you have an extra chromosome, you may have a condition called Klinefelter's. The Y chromosome has pieces on it or sections that are responsible for sperm production. So we can detect whether there's what's called deletions or pieces missing as a cause of your infertility. It's very important. I mean, these men who have genetic causes for their infertility, it's a condition they were born with, whether you smoke or whether you drank too much beer in college or lifestyle choices, has nothing to do with the fact that you have infertility. It's genetic and you were born this way. And that's very important to understand and diagnose. We can go ahead and in that case where there's some sperm in the testicle, but not in the ejaculate, we go in, we use a microscope, we dissect the testicular tissue and look for sperm that can be used with IVF, and that procedure is called a microtesty. But I would like to conclude that, as I mentioned, ICSI is really, has changed my practice in a very fundamental way, offers a lot of hope for couples with infertility. But having said that, it's really important to work together with a reproductive endocrinologist, because the female age is the one variable that we cannot change. And so the strongest predictor of fertility outcomes, even if there's male infertility, is really the female age. And so right up front, how old are you? How many kids do you want? What are your options? What's going on? How do we optimize things? How do we look at options and the pluses and minuses and the success rate of each of those scenarios? And our goal is to provide you with a positive experience and to work together with my colleagues to offer you the most efficient, personalized, and to take advantage of the technologies that we have at RMA.
All right, so it looks like we have some questions in the Q&A. I'll read the first. It looks like it might be more geared towards male fertility, but I'll read it for everyone to hear. So it says, if a male has a high concentration of sperm but a slightly below goal amount of normally shaped sperm, would you be concerned? I think it's 2% morphology instead of 4%. So it sounds like Dr. Brahama addressed this, but maybe he could restate it just.
Absolutely. I think that this is it creates so much anxiety when people, hear from, the nurse or OBGYN or a lab that their morphology, normally shaped sperm is 2% when it should be 4%. So again, let's focus on the fact that it is a percentage, right? A percentage of what? So if you have, again, a percentage of a high concentration, and that is more than the 4% of 40 million, it's really a non-issue, okay? The other thing that I think is important to realize is how these tests are done. So let's say someone has a count of 100 million sperm. Morphology is done manually, and it's done on only 200 sperm. So if you speak to a statistician, they're going to laugh at you. They say, really? You looked at 200 sperm out of a concentration of 100 million? That's not a good sample size, and they're right. So this specific aspect of the semen analysis is not optimal, and unless it's zero, it does not have a good predictive value.
And that's why I think it's important for patients experiencing infertility to see reproductive endocrinologists, because what happens is frequently the general OBGYNs or even primary care doctors, send this, and then they don't really have the expertise to understand that some pieces of this test are interpreted with more importance. They might read that and say, oh, it's abnormal, and then the couple thinks that the man has a major issue, and versus when I send it as the consultant, where the couple's coming to me with infertility, I right off the bat say, this is not a clear cause of the infertility. And I always say, unless it's really zero, it's not something that I would point to as a major contributing factor necessarily.
And so the next discussion, right after we go through the limitations of sperm morphology, it's really important to just jump to the next. How long have you been trying, right? If you're 35 years old and been trying for a year, that's not the same as a couple who's 21 and have been trying for 2 months, okay? And so therefore, let's get past this morphology concern, because it's not, and let's get a better understanding of how long you've been trying, what have you been doing, what else could be going on, is there an infection, do you have, some of the times we do more advanced sperm function tests like DNA fragmentation to assess whether there's a qualitative concern here on the male side. But really, let's, identify what is the strategy, and I keep going back to what is your 6-month plan based on what you've done up to now before you came for that initial visit.
Okay. So next question is about how susceptible sperm are to dietary behaviors. Like for example, even if someone is a normal body weight, but they eat a lot of sugar, would you say that that could be harmful to to sperm?
I think let's use common sense, right?
Mhm.
Exercise. People do talk about a Mediterranean diet. Um, you know, um, what kind of sugars, right? Are these, sweeteners that you have in that are produced,
Lab made or
yeah,
factory made?
factory made, toxins or exposures. I think that I keep going back to the conceptual model that you want to provide the best quality sperm because the amount of sperm is not that important, right? Because we can try naturally, we can do inseminations, we can do IVF, we can inject the sperm into the egg. That's not the issue. We always can bypass issues of concentration, but quality is really important and is a responsibility on the male, especially if a pregnancy is what is desired.
Yeah, and I'd say moderate, definitely if if it's something, if you ever say there's something in excess or you're eating a lot of it, then you know that might be a sign that.
But what let's flip that on the female side. What about lifestyle and dietary and weight
Hmm.
is
So,
affecting
there's
female?
been they haven't yet identified a specific diet that is, associated with fertility versus infertility, but certainly BMI or just weight, excess weight has been associated with taking longer to get pregnant, failed implantation with IVF, and with pregnancy loss. So there's definitely factors connecting weight and fertility. And I always, say, you know, focus on, um, whole foods, foods like fruits, vegetables, proteins. If you're going to have carbohydrates, it's best to have them from fruit or whole grains instead of kind of like white carbs, and I think a lot of it is things we know, and that is somewhat common sense driven from um, just from what we've learned throughout our lives. But we actually have a nutritionist available. That's a free service through RMA that's available to all our patients. And so I do frequently refer patients to the nutritionist to discuss more details because behavioral change with diet can be very difficult, and it can be a point of um, significantly added stress, especially if people hyper focus on it. And also, some people actually avoid seeing doctors because they think, oh, they're just going to tell me to lose weight, and I've been trying that, and I haven't been successful with that. So we try and help you with tools other than just saying, hey, just you know eat well and lose weight. It's we all know, I know personally that it's easier said than done, and so we try and help you
I
navigate
think that
that
you
as
brought up a
well.
very important issue that we try to address, right away from the onset. Is diet an issue? Is weight an issue? Well, we have the support. We have a dietitian to help you, and I think right from the initial visit, we encourage couples to take advantage of that, both on the male and
Hmm.
female side. We also have psychological support, right? So
Hmm.
if there's a lot of
Definitely.
stress and there's a lot of anxiety, we as physicians work together with psychologists and psychiatrists to help you deal with the anxiety and the stress of creating a family. So that's all part of Infertility 101. Right from
Hmm.
the beginning, let's identify the issues and provide the infrastructure and support for all of that.
Yeah.
One
Next
last
question.
question about diet. I was going to ask you, what do you recommend as for a woman who's trying to get pregnant? What should she be taking?
Uh,
A
uh,
supplement,
I say
prenatal.
really prenatal vitamin is the primary. You should be taking a prenatal vitamin when you're trying to conceive and when you're pregnant. Another thing is that I like to check vitamin D levels at an initial appointment. We know it is important for bone health, so at least you're helping that. And there are, some studies that show it is associated with some reproductive outcomes as well. And I find that most people who aren't already supplementing are low in vitamin D. So I tend to recommend that. But I am now finding more and more that people are on it from their primary care doctors and seeing more normal levels. But I really think I rarely see a normal vitamin D level in someone who's not supplementing it. So it's something that is a major health concern amongst our New York population.
Now, again, this is going back to the initial encounter. We are supportive of prenatal vitamins, which is critically important. On the male side, there's no downside. CoQ10,
Hmm.
antioxidants.
Yes.
There's no
So I
reason
I do
not to
discuss
do that.
those. Yeah, how there's some, some mixed data, but certainly it's not harmful to take
Mhm.
certain supplements like this one CoQ10, which is an antioxidant, is probably the most well studied of them.
And on the male side, it's important to realize that unlike in females who make eggs every month, we're producing sperm. It takes much longer. Sperm production takes 72 days. So certainly you want to optimize your lifestyle. If you want to take supplements, you have to realize that it needs to be in the system for that period of time to have an impact. It's
Mhm.
not from one week to the next.
Yes. And then another question says, 30, single 35-year-old, very low AMH. What are some causes? What could help? So, unfortunately, there is no reversing of a low egg count that we know of. Sometimes you can, for example, be on a birth control pill or be on some sort of medication. Primarily, birth control pills are what we see that can suppress it artificially, and then when you come off, we can see it go up. But short of that, if that is kind of the natural state, that is not something that is reversible. And so we can only kind of work with what you have from there. At 35, the average AMH should still be pretty good. So if it is significantly low, we may consider doing a workup for causes of premature ovarian insufficiency. Because you are at risk of early menopause, which is less than 40, depending on how low it is. And there's some genetic tests we can do to see if that's contributing. But frequently, there we don't find a good answer, and this is still an area that we don't know a lot about why certain people have lower egg counts than others, other than you're born with all the eggs you'll ever have. So it could have been that someone was born with less, and then everyone has a rate of decline. So it could just be that you were born with the same amount of average, but the rate of decline is greater. And again, these are really things we still have a lot to learn about. But there are a few known causes and genetic causes that we can look into when someone has early menopause, which means, cessation of periods and very low AMH before age of 40. But even if someone is younger than that with critically low levels, we would still potentially initiate a similar workup to see if there's any genetic causes that can be identified. From my perspective, when I see patients like this, we discuss two options. One is considering single parenthood because um, as long as you're releasing an egg every month, it really doesn't matter how low your AMH is because, again, AMH only tells you kind of what your reserve is, doesn't tell you what you're producing each month. So if you are producing an egg each month, whether it's one egg of many or one egg of few, it's still just one. And that 35-year-old has the same chance of getting pregnant as any other 35-year-old with good AMH levels that's also ovulating monthly. So this does not predict infertility. It really predicts your ability to respond to IVF, and also that you may go into menopause sooner than the average person, which is the average person is 51. And so some people hear that and say, okay, I may go into menopause early, IVF may not work that well for me, but you might get pregnant quickly with sperm exposure if you are ovulating regardless of your AMH. And so we have patients that pursue single parenthood, and decide that, what, yes, I maybe my plan A was meet someone, have a baby with a partner, but if that option may be difficult and I still want to have a child regardless of that, that single parenthood with using donor sperm would be an option. Another option is egg freezing, and with very low AMH you may only get very few at a time, but at 35 egg quality is still reasonably good. And, if we can get even, up to 10 eggs, and it might take 2 or 3 cycles, but, you can preserve your ability to have a child through egg freezing potentially. So I definitely recommend that you see a fertility specialist, sooner than later to discuss some of those options. Okay, next question would be, can you explain some reasons why a male wouldn't be able to ejaculate?
I assume that's for me.
I hope so. Yeah, I don't have a good answer for that.
Okay. So, common reasons, organic reasons include diabetes. Um, if people have had surgery in the prostate region, it can cause a sensation of ejaculation, but no fluid comes out. Um, Neuropathies, individuals who've had, uh, post-testicular cancer, nerve dissections, node dissections. That's where we see organic causes. Most likely, we see this in diabetics. But then there's a group of men who are able to masturbate but can't ejaculate when they're having intercourse. And so that is a situation that is predominantly psychogenic. But for all of these situations, we try to interject, if possible, behavioral therapy for the psychogenics. But ultimately, we have technologies such as electroejaculation. It's a procedure where we deliver electrical current and induce an ejaculate. We do that under anesthesia. And there's always the option of going to the testes and getting testicular sperm. It's similar to a situation like someone who's hysterectomy. There's sperm, it's just not able to come, it's not present in the ejaculate, or there is no ejaculate. So these are very treatable conditions. Again, because of the technology that we have, the threshold is low. We need a handful, a couple of dozen motile sperm to enable us to offer the ICSI technology. And for those men who don't ejaculate at all, and are, we have really multiple options to move forward with.
Yeah. And this is something that I see, again, either there's difficulty maintaining erection or ejaculation during intercourse. And really one critical question that I asked, the next question is, well, are you able to produce a sample through masturbation? Because if you can, then we have, easy options for you.
Exactly.
And
Right.
sometimes, we really, that's the only issue. And we may actually do things like natural cycle IUIs, in a young couple where that's the primary issue. And then sometimes I even find, I've had couples that say, like, once, if they know they're doing the IUI, then they actually have an easier time having intercourse, because then the pressure is off the intercourse. Again, going back to sometimes there's a performance anxiety, I call it, around kind of the need to do it. And I also, just like, we find there's certain conditions like something called vaginismus where sex is very painful, and the vagina can actually you can have muscle spasms, and it has some association actually with a history of like sexual assault, being having a history of trauma. Do you see that in like the male side too, that sometimes when there is difficulty with erection and ejaculation and sexual function, that can have some association with some history
Yeah,
of trauma?
yes. It's the psychological mindset of functioning sexually and is very influenced by those experiences.
Hmm. All right. So, oh, it looks like we have one more question. So I think that we have time for just one more, and then we'll be done. And I'm so happy to see so many interesting questions. And that we clearly had a need. We do this a lot. Egg freezing, female infertility, but a lot of these are male really focused, and tells us that this is something that was really needed, is to have you come on these. So that's great. So it says, if IVF is not producing viable embryos, is there still a chance of getting pregnant naturally? In other words, do some people just not respond well to the artificial stimulation and ICSI? I'd say yes. We definitely see couples who fail IVF and go on to have natural spontaneous pregnancies. Unfortunately, if there is trouble making embryos in the lab, and couples have unexplained infertility, I think that a lot of us think that there's probably a connection between those two things. That if someone is able to make and fertilize eggs, and then embryo development is poor, and they have a history of unexplained infertility, that could be actually an answer, or really uncovering something um, that is underlying the infertility. But the frustrating thing about, infertility is, like, my answer is, yes, you certainly could get pregnant naturally. The problem is, like, we can't tell you when, and we can't predict that, and we can't make that happen. So, we like to think about, well, what can we do, and what can we actively do to make this pregnancy happen, which is things like these treatments. Just, yes, you could always potentially get pregnant naturally, but we have no way of predicting that, or we have no way of increasing those chances, other than, if it happens, great, which we're here to try and do the active things to increase the chances, not just to say, well, let's just sit back and wait for it to happen, because then, it it may never happen. But it also, it always could. So I always, I've had many couples that have failed IVF, or at other practices, or with us, and then go on to have pregnancies. But unfortunately, we have no way of predicting who that will be up front.
I think I would just add to that discussion is the concept that there could be a male contribution to poor IVF ICSI outcomes, right? And that's something we're beginning to appreciate more. So that, yes, if the eggs don't, don't look ideal under the microscope, there's an egg factor, but the sperm may also be deficient, and we're seeing that the embryos arrest, or they don't develop, or they're genetically abnormal. And so that we have now also shifted in trying to, address whether there's a male contribution. And one of the things that we do is look at the male carrier type. We do that now for recurrent pregnancy loss, as well as poor IVF cycles. We move forward and do more advanced testing of the sperm quality, such as DNA fragmentation. There is some decent literature in those cases where there's really a suggestion that ICSI didn't work as expected, and there may be an influence by the male that we can process and get better quality sperm. Some people utilize testicular sperm, even though there's sperm in the ejaculate. They feel that might provide better outcomes. We've focused on microfluidic sorting to try to filter and optimize the sample to get a better quality sample. It's not an issue of do we have enough sperm, but can we filter out those that would produce better embryos? So there, in this discussion, there is now room for exploring the male as well.
All right. Well, thank you for joining. Thank you for participating with questions. We're here if you are in the New York tri-state area. Feel free to schedule consultations if you want more detailed, personalized advice. And good luck.
Thank you, everyone, for joining us. Take care.
All right. Bye-bye.